Okay, so what I'd like to do is try and give you an example of how we use research to influence policy and practice. And I'm going to use the UK as an example purely because I think the UK is interesting because our population now represents the global world. And also, we happen to work in a very politically driven, funded system. So although the people always say the National Health Service isn't political, that can't be true because it's funded via tax. Therefore, we have to be cognizant of the political environment. And I just want to give you, hopefully, a sort of a journey on how you sort of navigate that territory. Okay? Now, I know some of the audience, because some of you are master's students, some of you are PhD students, so for some of them I'm going to take a lot of what I said as read. And the others, if you don't know much about health policy, I apologise. I'm going to really gallop through this because I'm pushed for time, and I'm more than happy to be emailed afterwards, and I can give you some references, but I want to get to the end. So what do we already know? Hopefully you already know that health is unequally distributed in this country, okay? So yes, of course it is better than some other countries, I'm not denying that, but even in this country there is inequality in health. And people always say, well, it's only certain ethnic groups. Well, that's not true. So I don't know if anybody's seen on the news today about education outcomes. So there's a whole debate on the news this morning around not white children, but white working class children, okay? So they share the same ethnicity, but their social backgrounds are different. And that's essentially a really helpful introduction to what I'm hopefully going to focus on, that we actually need to think about social determinants of health if you're really going to make a difference to health. Because all too often we focus too much on the service. So we say we need more hospitals, we need more beds, we need more of this. Well, actually, in most good healthcare systems and countries where they have high rates of life expectancy, it's the social determinants of health, education, access to jobs, access to healthy diets, access to exercise facilities. They're the things that really make a difference. So what I want to just show you is in this country, we have actually had lots of government attention. So we're quite fortunate that successive governments have actually focused on health inequalities. And I've just listed here a series of projects that have been done. And if you don't read very often, if there's one read I could recommend to any person, it doesn't matter if you're a student or staff, is to read the Marmot Review. Okay? Please read the Marmot Review. Okay? Because it really shows you, one, what things are going really well in this country, but also how things are not going too well for certain sections of our population. Okay, it's. I don't say this for most reports, and I wrote lots of them as well. They're quite dull and boring, but that is a riveting read. Okay, so just to illustrate the point, what you want to think about is actually health, not in terms of ethnicity, but really in terms of social gradients. So again, the same headline this morning, I mean, it's a great coincidence for me. I think they've used a similar slide. I was checking the BBC website before I came in. So people compare the Indian, the Chinese, the Afro-Caribbean, and the Pakistani and the Bangladeshi in terms of health outcomes. And I always say, but what about the white working class? Because they actually don't get much visibility in healthcare. Because I suspect if you did look at the white working class, they would have poorer health outcomes, or as poor as some of the ethnic communities. And again, that's for very political reasons, because a lot of the funding, and I'm a researcher myself, when I apply for funding, I know that certain populations are more likely to be interesting to funders than others. That's just the reality of the environment we work in. So we have to be cognizant of that. So for me, what are we going to do about it? So what I'm interested in is about how do you deal with those underlying determinants. So how do we deal with smoking? How do we deal with diet? How do we deal with kids and their circumstances in which they're born in? How do we deal with the fact that people don't have access to decent education, as illustrated by the news this morning? And So in my list of things, health and social care services comes at the end. Because I think that's only supposed to be there when you become sick. And surely, in any progressive society, we need to be moving towards a situation where people are disease-free. That's where we need to be aiming for and aspiring to. And the example I always use, if you ever go somewhere and you have to pick one country to visit, not just for a holiday, but to look at healthcare systems, I always recommend go to Cuba. It's really, really interesting to see what Cuba have achieved. And that's because they've really focused on primary care and public health. And that's because they don't have the money to have these huge super-duper hospitals with high-tech equipment. So they've really focused on trying to keep people disease-free. So I'm lucky, as well as holding a chair position here, I was allowed for a good number of years to work in the healthcare system. So I chaired it was called a Primary Care Trust, they're commissioners for Bedfordshire and Luton. And I just want to share with you some of the work we did in Luton. So what I was able to do, because I was able to chair the board, I was able to basically say, look, I can tell you what the evidence says, what we need to do for this town, but it will only work if we take an evidence-based approach and not a political approach. And the only way you can make that happen, as I've learnt and I want to show you, is you need to show the politicians that there's a win-win in what you're trying to achieve. Because if you don't do that, you're not going to achieve anything. So what I tried to do was understand the political context, get my local politicians and national politicians on board, and then most importantly, undertake something called a health needs assessment, which the students should be familiar with if you're doing the masters at least, which actually, it's quite disappointing to say, very few, even now, healthcare systems undertake a healthcare needs assessment of their local population. They just make a proxy decision based on national data. Oh, well, this must be what's happening in my local population. You don't know that for sure. So we undertook a healthcare needs assessment, and then we worked with partners to realise our ambitions. So we knew, this is just sort of headline findings for Luton in terms of our healthcare needs assessment. We know that Luton, relatively speaking, is a less healthy town compared to other average life expectancies. So in this town, men live only 76 years, women live only 80 years. I'm not going to go into it now, but I always wonder why women outlive men. But let's not go into that now. No. It's interesting though, isn't it? And in Luton, what is it that sort of stays with people? So it's diabetes, cardiovascular disease, and these are mainly attributed to smoking and diet. And there's huge inequalities in this town. And we have to remember that over 50% of children in this town are non-white. So projecting forward, take this forward now for the next 10 years, we're going to have a very different population in this town compared to what it was at the current stage and what it was 10 years ago. And I don't know if anybody's familiar with school years, but year 6 means, I'm going to get this wrong, aren't I? 11-year-olds, I think. So at the moment, 1 in 5 children in this town are obese by the time they're 11, right? That's not good, in case you're wondering. That's just not good. All right? Now, I say that's not good because other people will say, well, I come from a country where it's worse. So, for example, I do some work in Qatar. In Qatar, 70% of their Qatari population is obese. So they're saying 20%, what's the problem with that? Well, 70% is seriously not good. 20% in Luton is not good either. Because obviously that potentially could lead to all sorts of long-term conditions developing. And we also know there's lots of complex disability in this town, and dental health is a big issue. So we did this healthcare needs assessment. We then produced a map and said, well, where is it in this town that this is most prevalent? And the reason I say that is, I said to you at the beginning, we are in a publicly funded system which is politically driven, which means, by necessity, you have to prioritise and make difficult decisions. And what I argue is, if as long as you're clear with your public and your local politicians what your parameters are on which you're making those priorities, then on a good day, they'll go with you. But if it looks like, this probably doesn't translate well in different cultures, but if you do a finger in the air job of parameters, that doesn't work well. You don't really take people with you. So we knew, based on life expectancy, based on chronic disease prevalence, that the areas to work on in Luton in terms of priority need were wards called Dallow and Biscot. Some of you who are familiar with Luton may know these wards. Marsh Farm and Farley Hill. So how are you going to deal with it? So we went out to the public. We said, look, we've done this healthcare needs assessment and we're going to tell you what we found. So we went out and we said to the public, look, we want to be your champion. And we did a series of evening meetings. I remember them because they also happened to be coincided with another football tournament, wasn't a World Cup, and I was quite upset because I like football, so I had to sacrifice a few football matches to go and do these public consultation evenings. Great. And we went out and said to the public, we want to be the patient's champion, we want to focus on value for money, and we want to think about having different providers in the town. Now that doesn't equal privatisation. Don't know if you ever read the news in this country. We've got this big thing about, oh, don't privatise the NHS. That doesn't mean you shouldn't have competition. So I'll give you an example. If not that mine is, if my GP is rubbish, right, I should have the right to find another GP if my GP is not willing to improve themselves. Okay? That's competition. I think every member of the public in this country and for the world should have that right. So that's what we were saying to the public. Surely we're showing you that because of these healthcare outcomes, because of the current rates of obesity and all these other chronic conditions, something needs to be different because the status quo isn't working. It can't be working because if it was working, we wouldn't have this situation. So again, we worked with the public and we used this sort of model where we sort of said to them, look, one of the things we need to do is you need to think about health through prevention and education, because unless you work with us, there's only so much we can do, because we'll end up just being a sickness service, we're not a health service. And we also need to prioritise, so we're going to focus on the areas with the lowest life expectancy, and Luton not too dissimilar from most towns. Actually the most vocal parts of the town, i.e. the people who come to most public meetings, go to the council chamber, tend not to be the people from those wards that have the lowest life expectancy. So we needed to go out to the whole town and every ward and say, look, we've got to prioritise. And when we hopefully persuade ministers to give us some money and prioritise in those areas, you need to be with us to say this isn't a competition, we want to focus on these wards, and we're explaining to you why. And also, we want to test the market. We want to see who else can run primary care and public health, because surely we don't want the same providers running it, or if we do, we want to make sure they're up to scratch, because if they were up to scratch, with all due respect, we shouldn't have the data that we currently have in front of us. And the other controversial thing was, again, I've done a lot of research on care pathways. It's not rocket science, but the closer care is to someone's home in a familiar environment, the more likely you are to access it. So we want to move some things which are feasible to move from acute into community, but then that needs the right level of community nursing, district nursing staff as well. But again, that you've got to take the public with you, because not just the British, but most countries that are obsessed with hospital buildings. Yeah. I did some work in Bradford once, very quick story, where we closed a diabetes ward and we moved the outpatients into the community. The patients loved it, they'd all gone. And anyway, about a few months later, somebody had then noticed in the hospital the ward had been closed. And they contacted the local press and they managed to have hundreds of people stood outside St Luke's Hospital saying, don't close our ward. And I was thinking, but we closed it 6 months ago and the patients are all in their community clinics and they're all happy and their blood sugars are being well managed. But it was a great example for me about how easy it is to politically mobilise clinicians and the community around the hospital setting. I could never get the same picket line for like a district nursing service. It just wouldn't happen. just a harsh reality. So understanding the political context is not just about politicians, it's also about understanding the political context of the town you're working in. So some of you will be familiar. Luton, like all towns, sometimes does have tension. So there's lots of community tension in the town when we're doing this work, and we had to be cognizant of that. And these are just sort of examples. And the reason we had to be cognizant of this was if we were going to go to ministers for funding, they would want to then be reassured that we're going to deliver on this, and they'll be thinking, well, hang on, there's a bit of disruption going on in that town. Are you really going to be able to deliver certain new potential services in certain wards when there's already a bit of underlying community tension? And so we showed them, and this is, I suppose, a risky strategy. We showed them all the evidence and basically said it's seriously bad in the town. So I commissioned, not this university I hasten to add because I had conflicts of interest, another university to do a primary care needs assessment. And we found that actually, as a town, based on the population we only had half the amount of primary care space and capacity for the patients that needed looking after. So we had to do something about that. And also, we knew from the earlier health needs assessment which wards needed priority. So what do you do about it? Are you familiar? I'll explain it actually. In this country, we have something called single-handed GPs. They are doctors who operate on their own, okay? Now, that in itself isn't a bad thing, but if you've got 12 of them in one particular area, that's quite risky. Because essentially, if they're not sharing data and benchmarking data with each other and their peers, you've got a problem. So we were very, very cognizant of that. We also had, in some of these priority ward areas, huge diversity. So I always sort of say Luton's a global town. Over 100 languages spoken, great food, brilliant for me. Not always healthy, I hasten to add. But can't resist. And we also have lots of housing issues and schooling issues in some of those areas. So we knew there was a whole suite of measures we needed to deal with, not just about primary care. So how do you deal with it? Well, people who know me, you will know, actually, if it goes back to my comment about being a Wolves supporter. If you know anything about football, Wolves are a rubbish team, right? So by definition, if you've supported that team all your life, you've got to have a certain kind of personality. So I'm a natural optimist, right? You've got to be to support that team, right? So therefore, when it came to this, I can solve anything, because everybody had told me, politicians, right, you've got nowhere, even if you persuade the public to buy into this, you're never going to be able to build anything because no one can find land. And I got chatting to this vicar, and she was going to have a Women's Day in a church, and I was like, wow, Women's Day in a church, I must come along. That's come out wrong, but I thought, we're in staying at church. I said, how do I get along to this Women's Day in a church? And she said, well, actually, it's for the local Muslim community predominantly, because they live there. I want to talk about positive health. So I said, look, I'm going to get all of our community nurses who are available, and they'll come and do some blood sugar testing, blood pressures, height, weight, the full lot, okay? But I said, I want to come along because I knew this church was about to be knocked down and redeveloped, and it was going to be developed into community housing. And I said, if I can go there, and I'm not saying this is true of every household, but in some households, women have a bit of influence. Okay, so I thought if I can persuade do you think I dealt with that really well? So I thought if these women can be persuaded that as well as community housing, we should have a health centre here, I've got half a chance. So I don't know how this works, but I was for the day an honorary woman. Okay, that was the only way I was allowed to go to this event. So I was like, that works for me. I'll do anything. And I went and I spoke to them. I said, look, on this site, it's a massive site, I know you're short of housing. Can we not have housing, church, which they're going to keep, and a health centre? Because surely you're not all happy with your GP. Now, the interesting thing was they all agreed it was a really good idea, but none of them fancied the idea of leaving their GP. Even though they agreed, they probably weren't that good. But that's a story for another day. So what we said to them was, okay, That's fantastic. So they were able to go with us, and we then said, okay, we want to put this out to tender. And I was lucky enough, so Anne will know, to go to Richmond House and sit with the Secretary of State, who at the time was a gentleman called Alan Johnson. And I basically said to him, look, I've got here a petition of Luton residents saying these are the wards we want to focus on. I've also got, and I showed him the photographs of a potential site. I got no money, right, to do this, because you're not doing this at the moment. And this was about the time when the government, I knew, were about to introduce something called Fairness in Primary Care National Procurement Process. I love these acronyms. And I know how governments work. They have to pilot these things. So I said, I want to be your pilot, which is risky, because if you get it wrong, you look stupid. I'm used to looking stupid. I support wolves, so it doesn't matter. Yeah? So it's fine for me. So we volunteered, we got the money. So this was what the church was, and then gradually just redevelops. And basically on the left now, you've got a health centre, middle is a community cafe, on the right is a church, and there's a bus stop, because you need people to be able to get to these places. Oh, and there's a huge car park behind as well. And one of the things was, so remember I said to you, there was community tensions. So this was the first space that we ever had in Bury Park where there was most tensions, where literally, can you imagine, you've got people who are congregation Christians, people who actually live in this area predominantly happens to be Muslim, for the first time actually meeting together in this community cafe while they're waiting for whatever it is. Could be either a GP surgery or a blood pressure check, and on the right it could be some kind of church play group or something. And surprise, surprise, do you know what? They've got the same issues. They all whinge about their husbands. Did I say that? They all talk about their kids at schools, all that sort of thing. And they realised, you know what? We've got probably more in common than we thought. So this is what I'm saying. It's about a win-win. So we've created this space and facility. We've got staff who like to have their photos taken, who also are from the community. They can speak many languages, they understand the needs. And also we consulted on opening hours. So again, Anne will be familiar with this. There's a gentleman called Lord Darcy who then years later opened these things called Darcy practices. I keep joking that he nicked my idea, because then he started, surprise, surprise, wanting to open 8 till 8. Well, we did that way before he did, because the public said we'd like them open 8 till 8, before school, after work. They want pram pushchair facilities, because they said lots of youngsters. We said we can do that. Children's play area. So all these things, if you take the public with you, you can deliver. And they registered over 4,000 patients, which in NHS terms is pretty good in the first 14 months. So that was great news. And then, as I said, we were lucky, because then Lord Darcy came along and he introduced his Darcy centres. And in that policy, it was you were only allowed 1 Darcy centre per site, i.e. per PCT. So I'm a bit pushy. So I again went back to ministers and said, I've actually got 3 other wards that I've promised the public if we were to prioritise we'd go with. So instead of having 1, could we have 3? Is that all right? But the easy thing was I could show them, 1, we had the petitions to prove that the public had agreed on these sites. And most importantly, I had sites. We'd worked with the public to identify sites so that if they gave us the money, we could genuinely open these things. So by 2011, we'd increased capacity in primary care in this town by 30,000 patients, which is huge. It was the largest growth in primary care capacity. And the deal is, and this is where I go back to what I said about understanding the political context, all I had to do to make this work, with all due respect to Anne, is to make sure all the politicians could be photographed for all these sites. That's the win-win. No, you didn't. You didn't get in on that gig. You didn't get in on that gig. And we opened a Change for Life Advice Centre, and, as I said, moving things out the hospital. So any medics in here, you will know, you don't need endoscopy in a hospital. Yeah, you don't. You don't need retinopathy in a hospital. You can do all this stuff at home, and this is just a busy slide showing you where the branches were, and the yellow ones are all the new surgeries. And again, that just shows you based on deprivation. So the chappie in the middle was Ben Bradshaw. I know, but he was the minister at the time. Deals I do with the devil. You know, I said I'd do anything. You know. I know. Are those rumours true then? This is Kelvin Hopkins and said minister, and then local councillors who were really helpful in finding us a site. So if these councillors hadn't located this site in Marsh Farm, those facilities wouldn't be there. And it's about giving coverage, and I love this. They've actually moved this site now, but this was open in the Arndale. It's Change for Life Centre. And just show you who this is. So this lady's the Director of Public Health for Luton, Jerry Taylor. Some of you may know her. She's doing dance aerobics. That's the Lord Mayor. He won't mind me saying this, but he needed to lose a few pounds. That was the High Sheriff. This is a Professor of Sports Science. And this was the Chief Executive of the PCT. So it was about getting the movers and shakers of the town to really feel part and parcel of these developments, because they can go out, use their social networks to make these things a success. Yeah? Otherwise, you open all these facilities and you don't deliver. And we were lucky because of that health centre I'm talking about, which was imagine, you've got a church and then 99% non-white, non-Christian patient population, all co-located. I had no media wanting to run a story on that healthcare centre. And I'd spoken to a lot of the journalists on the phone myself, so I was glad that I did it myself because I wouldn't have believed it. And they said to me, unless you can find me someone who's unhappy about the centre being shared by Christians and Muslims, we're not going to run a story. Okay? And I was like, that's fine, just put the phone down, it's cool. Because the most important thing for us was people are able to access the facility, people are able to access healthcare, and most importantly, get to know different people who they wouldn't always get to know. So really, in summary for me, if you really want to tackle health inequalities, as I said, this is less so about health services. You've actually got to take the public with you, and you've got to deal with community cohesion. Because if you deal with that, then places like schools, workplaces, all of these different environments, you're all going to be thinking about positive health and doing good for each other. And then all the stuff around healthcare facilities kind of follows. But if you haven't got that relationship within a community, it's very difficult, because what people then do is they compete. So my blueprint for the future, which the current government has ignored, but doesn't matter. I'm used to that. So at the moment, we've got something called clinical commissioning groups. They are responsible for commissioning, so they've got most of the money. So my argument would be, is at the moment, I don't know if you've again seen on today's news, there's a £2.5 billion funding gap, right? That tells you something needs to change. So I would argue, in political speak, we need system reform. We need far more stuff focused on primary care and public health, and I know it's not politically correct. We need less attention on hospital care unless there is sufficient patient need. There are still, I know that there are enough hospital beds in this country, but if this makes sense, they're in the wrong parts of the country. And it's very difficult to move them, because as soon as I said, you try and move something, there's all these big pickets saying, save our hospital ward. And if you're going to do this, you've got to focus on reducing health inequalities, because if we don't do that, every few years, we're going to have a funding gap. So we've got to be serious about this. Value for money is really, really important. So I call it health economics. NHS people call it quality improvement, prevention and productivity. They love acronyms. And we need clinicians to go with us on this. So I'm working on, there's colleagues here who probably will share with you later on all this work now on remote healthcare and doing things differently. But unless clinicians tell patients the benefits of working differently, patients, quite rightly, and I'm one of them, will become cynical. So it's up to GPs and nurses to say why we're doing telephone-based consultations if we move to them, or why we're doing video-based consultations. Because unless we explain that, people are going to say, well, isn't that just you trying to save money? So, and we have got to focus on populations, and we do need a healthcare needs assessment. And I've got a great example for this. So my gran lived until her 90s, fantastic woman. And I sort of spent about 2 or 3 weeks with her in the last 2 or 3 weeks of her life, just watching all the people coming into our house. It was really interesting because in the morning, the health visitor or district nurse or someone used to come. Then someone from social services used to come. And except for probably 1 or 2 questions, they were all the same. And it was getting quite tedious because not that I'm patient anyway, but to ask me the same set of questions about my grandmother who's not got very long to live, it's not a good idea. So I was just saying to them, why don't you from the morning share that data with the people in the afternoon? Is that complicated? And they were like, oh, our systems don't talk to each other. You know, so we can solve that. So that people genuinely then see that their health and social care needs assessments can be done together. We need to move activity from secondary to primary care. All the data from all around the world shows, as I said earlier, if you move care closer to home, doesn't have to even be in a healthcare centre, can be in your local school, your place of worship, you are more likely to access it if it's in an environment that you trust and you're confident about using. As I said, that's politically difficult because people think you're trying to close down a hospital ward or something. Well, yeah, we are. Yeah, we are. But you've got to be honest with people about why you're doing it and what the benefits are about doing it. Hence, you've got to take the public with you. If we don't take the public with us, which is what people find really tricky, we always want to say we're investing more money, we're always saying we're living longer. There's a £2.5 million gap, inequalities in this country are widening. That's fact, but you won't get a politician saying that. That's the difficulty. So we've got to focus long term on health and well-being. How do we get this country to think genuinely about positive and healthy well-being? I see that most people are drinking water, so I can't make my usual dig about what people are doing. And we've got to think about community services. I think this is the Cinderella service in this country. If there's one thing that I think has been completely neglected, it is community services. You know, community nursing, even as a sort of a profession now, is on a decline. But when you think about people who get discharged from a hospital, they need that community care. The same with the people who get admitted into a hospital. A lot of them need that community care. It's shambolic at the moment. And this is code. Acute services review really is code for we've got hospital beds in the wrong part of the country. And I think unless you have a country who is willing to deal with this, you will have huge problems. This requires working in partnership. And finally, you can only do this if we deal with health and social care. Because as this British population ages, we're going to have a growing and growing elderly population who will have both health and social care needs. So that's my sort of blueprint. Hopefully people may take this forward, but if you do this, most of the evidence suggests from most countries that deals with reducing health inequalities. But you need the public and the politicians to go with you on that. Thank you for listening.
As expected,